Welcome to Sight and Sound Bites. I am Heather Cronus-Danek, Senior Director of Development for Individual Giving at the Eye and Ear Foundation. We have an exciting talk today, and I'm very honored to introduce today's speaker. But a little bit more about the Eye and Ear Foundation. The Eye and Ear Foundation is the fundraising entity for the departments of Otolaryngology and Ophthalmology at the University of Pittsburgh School of Medicine, both world-renowned programs. Every dollar raised goes to support research that helps with head and neck cancer, the worst vision problems, balance disorders, and hearing problems. Today's topic is HPV and the changing epidemiology of head and neck cancer. And I'm very honored to introduce Dr. José Zevallos, the Eugene N. MD, Professor and Chair of the Department of Otolaryngology at the University of Pittsburgh. Dr. Zevallos joined us in the summer of 2022, and he is only the third otolaryngology chair we've had since 1972. We're quite like the Steelers in that way. So, Dr. Zevallos, welcome.
Thank you, Heather, and thank you all for being here. It's really a privilege to be able to do this this session with you, and I really couldn't be more grateful for the support of our foundation. The foundation really is a partner for this department as we try to grow our academic mission and hopefully impact lives through research. So today I'm going to talk about a topic that's become, really has now become more mainstream in terms of understanding, but I also would think there's a lot of room for us to continue to educate folks about, and that's HPV and how it impacts specifically head and neck cancer. As was mentioned, I'm the chair of this department here at the University of Pittsburgh. Some disclosures, I'm the founder of a company called Droplet Biosciences, unrelated to this talk. I also, I'm an equity shareholder of a company called Vine Medical in California, unrelated to this talk. I have a grant from Merck to study HPV vaccination, but I have no, and also received some grant support from them. So my name is José Zevallos. As I mentioned, I'm a head and neck surgeon. I run a research lab at Hillman Cancer Center. Prior to coming to UPMC, I was the director of head and neck surgery at WashU and Siteman Cancer Center in St. Louis. I also have an entrepreneurship background with the companies I mentioned. So it's really a pleasure to be here at the University of Pittsburgh, which, as Heather mentioned, is one of the leading programs in the country and really in the world when it comes to head and neck cancer, clinical care, and research. And what makes this place particularly strong is our people. We really have a world-renowned faculty here across the entirety of otolaryngology. And we've added several new people. So here are the 8 new people that I've recruited since I've arrived in the last year, coming from really the best institutions in the country, including MD Anderson, University of Michigan, WashU, the Harvard program, and Mayo Clinic. And these folks are going to really add to the richness of our department and contribute to our research in new and exciting ways. So I'm really excited to welcome them all here to the department. So for today, I'll be talking about HPV oropharynx cancer, as well as how the epidemiology of this disease has changed in the last 20 years. We'll review the epidemiology and presentation of cancers of the oropharynx caused by HPV. We'll talk about how cancer outcomes have changed as a result of HPV and oropharynx cancer. We'll talk about some new treatment patterns for this disease, including treatment de-intensification, as well as the role of speech therapy and other ancillary services when it comes to treating this disease. So first of all, backing up for a moment, I want to really review what head and neck anatomy means, because I think a question oftentimes comes, well, what are we actually talking about when we talk about head and neck cancer? We're not talking about cancers of the brain. We're not talking about cancers or diseases of the spinal cord. We're talking about really what we call the upper aerodigestive tract. If you look at that picture in the middle, this is comprised of the nose and the pharynx, which is the back of the throat, divided into 3 parts: the nasopharynx, so the part behind the nose; the oropharynx, which is the topic of today, behind the mouth, so it's the throat behind the mouth, including the uvula that you see in the middle, the area that hangs down from your palate, and the walls of the throat. It also includes the tonsils and the very back of the tongue. The hypopharynx is the lowest part of the pharynx, which is around the voice box, which we also call the larynx. And you can see here on the right, this is a picture of the vocal cords. That's the larynx. The pharynx is kind of behind the larynx. And when one looks in the mouth, you can look back and see that portion of the pharynx called the oropharynx, which is what we'll talk about, as I mentioned. And here it is closer. The uvula is the thing that hangs down in the middle that arises from the soft palate. And then you have your tonsils, as well as the base of the tongue, and then the walls of the throat. And one of the unique things about this part of the throat compared to others is that it's comprised of immune cells. It's comprised of lymphoid tissue, very similar to lymph nodes. They are essentially large lymph nodes, the tonsils. And when you look at the base of the tongue, the tissues in the base of the tongue are also lymphoid. They actually look like tonsil tissue in many ways. So that there's a uniqueness to the oropharynx that you don't see in other parts of the throat. And there's more to come on that, but that's why I think we see unique cancers of that area, namely HPV-associated cancers. So when we think about head and neck cancer, and the way we've thought about head and neck cancer for decades is cancer is caused primarily by heavy smoking and drinking. There are some other risk factors such as poor oral health, previous radiation, Epstein-Barr virus, but the vast majority of cancers that we've traditionally treated in the head and neck are cancers caused by smoking and drinking. And here are a couple of examples of cancer on the top here of the voice box. These are the vocal cords. You can see a cancer arising from there. Cancers of the tongue or of the alveolar ridge or the dental ridge that houses the teeth. But what happened was over the course of the last 20 years, really, we've started noticing that patients who don't necessarily have the traditional risk factors for head and neck cancer started developing cancers of the oropharynx. Now, oropharynx cancer has traditionally been a relatively minor subset of all the other head and neck cancers. The most common cancers of the head and neck are oral cavity or mouth cancers, not oropharynx or throat cancers. And we started seeing, beginning around the early 2000s, an increase in cancers caused by, at that point, an unknown entity that were characterized by occurring only in the oropharynx, so really only in the tonsils and the base of the tongue. They weren't occurring in the oral tongue or the voice box. They were associated with not necessarily associated with smoking and drinking. So we started seeing people who don't have the traditional smoking background developing these cancers. And they also had better outcomes. The patients responded better to therapy. And over time, it became evident through discovery that these cancers were in fact being caused by HPV, or the human papillomavirus. So what is HPV? HPV is a small circular DNA virus. There are over 100 different unique types of HPV that cause everything from cancer all the way to benign warts. There are high and low risk groups that have been fairly well defined. And HPV, we know, causes cervical cancer in women. It also causes anal penile cancers in men. And we now know it causes oropharynx cancer. And HPV as a cause of cancer has been incorporated into screening for cervical cancer, namely through pap smears. And that's reduced the rates of cervical cancer dramatically because it allowed physicians to capture those cases before they converted to cancer. So what about head and neck cancer? So HPV positive oropharyngeal cancer, there are over 50,000 new cases annually in the US. And as I mentioned, cancers of the tonsil and base of tongue can occur in smokers. It's not always HPV, but nowadays in our clinics, the vast majority of cancers of the tonsil and base of tongue are caused by this virus. Patients who present with HPV cancer can be the entire range from the youngest patient I've ever seen is mid-30s to well above 70 or even 80. But we do note that there is a little bit of a younger trend in patients with HPV positive cancer compared to the typical smoking cancers. So we see patients typically in their 50s, whereas cancers caused by tobacco tend to occur on average at least 10 years later. What's really interesting about this cancer and this virus is that there's about a 30-year latency period between infection with HPV and the onset of cancer. And what does that mean? It means that most people get infected with HPV in their late teens and early 20s when they become sexually active. Most people who are infected with HPV and have an acute infection are able to clear it immunologically. They're able to get rid of it completely so that if you test them again 6 months later or 9 months later, that you can't find HPV anymore in their saliva. There is a small subset of people who are not able to clear the acute infection and convert to a chronic infection. And that chronic infection festers in the crypts of the tonsils and the base of the tongue. And it takes about 2 to 3 decades for that chronic infection to transform the cells of the oropharynx and form cancer. So the typical infection time is in the teens and early 20s, but the typical cancer patient presents in their 50s and 60s. Now, why some people go from acute to chronic infection remains unknown. We have some hypotheses related to the immune response to HPV, but we haven't yet developed a test to screen for patients who will go on to convert to HPV. So someone may ask, well, if we know it's a risk factor, why don't we just test everybody for HPV? And the reason is because most people who have infections will never, ever get cancer. And that's really the challenge of screening in this population, that if you have HPV, the likelihood is you will never have any problems. But capturing that subset of people who have infections is really a big challenge. Cancers of the tonsil occur more commonly in the base of tongue. We see it in non-smokers, but we also see it in smokers. And we know that smokers with HPV, when they have those double etiology, smoking and HPV, you have worse outcomes than if you have HPV with non-smokers. Typically speaking, this cancer is associated with better oncologic outcomes. They respond better to surgery, to radiation, to chemotherapy than HPV negative cancers. And that's led to a rethinking of how we treat these tumors. And as I'll talk about later, it's led to treatment de-intensification clinical trials like the one we have here at Hillman. So how do these patients present? They present very differently than your HPV negative head and neck cancer patients. So HPV negative patients, smoking-related tongue cancer, for example, they tend to present with very painful ulcerative masses of their mouth that allows them or makes it difficult for them to swallow, to speak, weight loss, etc. And they also can present with lymph nodes in the neck, as you can see in the picture here. However, for HPV positive cancers, most patients are essentially asymptomatic in their throat. They have no symptoms of anything until the tumor gets quite large, caught from the tonsil or the base of tongue tumor. And the reason why we think there's such a dramatic difference in terms of how these patients present clinically is, as you can see in the bottom there, the cancers of HPV arise not on the surface of the tonsil, but they arise deep in the crypts of the tonsil. And they grow there for some time. They can even spread to lymph nodes before they really break through the surface of the throat. And we think that that causes there to be less symptoms as the tumor grows in the tonsil or the base of tongue. However, we have noted that these patients tend to have small tumors of the throat, but then they have lymph nodes, like the one you can see in the picture A and B there, that tend to be cystic, that arise in the neck. Now, the good news is that even with lymph nodes being positive, because most of our patients come in to see us not because of something in their throat, but because they feel something in their neck, most patients who present with lymph nodes in their neck, and sometimes even big lymph nodes, still have excellent prognosis. Some more advanced cases, not quite as good, but most patients, even when they have lymph nodes in their neck, can still have a really excellent prognosis. This is a marker that we use to test HPV in tumors. It's called P16, and it really has been the only biomarker. It's hard to believe, but it's the only real biomarker that is in clinical practice today for head and neck cancer. And this is a very, very prognostic, it's prognostic, but it's also a very good surrogate for HPV infection when used in the oropharynx. So what's happened with HPV in the United States over the last 30 to 40 years? And it is a paper that was a very important paper published in 2011 by Chaturvedi et al. in JCO, where they looked at the incidence or the rate of HPV cancers as well as the rate of oropharynx cancer overall in the United States, beginning in 1990. And as you can see here, in yellow, the overall rate of HPV of oropharynx cancer has increased by 28% over this time period. The rate of HPV negative cancer in gray has actually declined over the last 20 years because people are smoking less, which is a good thing. But what's happened is the overall rate of oropharynx cancer has increased because HPV increased by 225% over that time period. And HPV oropharynx cancer is now the most common HPV-driven cancer in the United States. It has now surpassed cervical cancer in that mark. It's more common, likely or certainly as a result of the fact that we have an effective screening mechanism for cervical cancer, namely the Pap smear. So we are now dealing with the most common HPV-associated cancer in the US. The rates continue to increase, and they will likely increase by even more over the next 20 years until vaccination, which we'll talk about later, becomes more widespread. So this is a clear and present problem that we're facing on a daily basis in our clinics and across the country. And what about the rest of the world? So this problem of HPV is primarily currently a problem of developed nations. It's a problem that we see in the US, we see across Europe. It's not a problem that we see primarily in underdeveloped nations, although it is beginning to increase. I am originally from Peru, which is on the western coast of South America. And what's happened in Peru is probably what's happening in other countries like this, is that the more Western or modern capital cities like Lima, we're seeing much more HPV-driven oropharynx cancer, whereas rural areas either aren't tested or we're just not seeing the same rates. And it's not clear why that is, except that this is very, very closely linked, as I'll talk about next, to sexual activity. And as that changes in more developed, we certainly see a difference between developed and underdeveloped nations with respect to some of these factors. So oral HPV infection is the cause of oropharynx cancer caused by HPV. But as I mentioned, it happens 20 to 30 years earlier than the development of cancer. So this was an important study from the NHANES, as a population-based study in the United States, where they measured not cancer, but infection with HPV in adult men and women. And you can see here on the top that there is a bimodal distribution, which means that if you were to measure people across all different age groups, the folks that have the highest rates of HPV in their saliva, in their mouth, are, as you can see here, in the 20s and again in the 60s. You see that both in men and women, but it's primarily significant in men. And as I mentioned, the reason why you see that initial peak is because people are becoming sexually active and therefore they're being exposed for the first time to HPV. The reason for the second peak in the 50s is really unclear at this point. It's not a midlife crisis or anything. It's certainly not that. We think it's that as we get older, our immune response become diminished, and therefore a previously active infection begins to manifest. Interestingly, that's the same time when these cancers develop. So this gives us a clue about the role of our own host immunity in protecting us from this infection and ultimately from this cancer. We also know that the number of sexual partners, lifetime sexual partners, is directly correlated with the risk of HPV oropharynx cancer. And you can see here that the risk goes up, of infection goes up significantly, and we know that the risk of cancer goes up with an increasing number of sexual partners. So one of the questions I often get asked is, what about transmission of HPV? And we know that oral HPV itself is different, of course, than in HPV positive cancer. We also know that oral HPV is very, very common. So about 8% of US adults have HPV in their saliva, and 4% have high-risk HPV in their saliva. And as I mentioned before, most of those people will clear it. We know that HPV is not casually transmitted by sharing drinks or a kiss on the cheek. And we also know that partners, somebody comes in with an oropharynx cancer, one of their first questions is, am I giving this to my partner? The likelihood is your partner has already been infected with HPV, and it's not going to cause them any problems in most cases. And we know that exposure, as I mentioned before, does not equal cancer. So what do we tell our partners of our patients with oropharynx cancer? We tell them that the risk that they will have cancer is about the same as the general population. There's no increased risk, as far as we can tell, from having a partner who has an HPV or oropharynx cancer. We also know that former and current partners have already been exposed, and exposure, as I mentioned, does not equal cancer. We also tell them that their sexual life should continue with their partners, but they should consider protection with new partners. And typically, the people that get this cancer are primarily and predominantly men. So we always tell them or their partners that they should follow guidelines for cervical cancer screening, just as everybody else in the population does. But there are no additional recommendations that we give because a partner has oropharynx cancer. So let's talk a little bit about the vaccine, because this is really an important topic that is, has political and social ramifications. But I want to talk about kind of the facts for today. So the vaccine, interestingly, of all the cancers that I treat as a head and neck surgeon, the vast majority of these cancers are completely preventable. And it's not common to be able to say that, but many of our HPV negative cancers caused by smoking and drinking are preventable. And HPV oropharynx cancer is completely preventable through vaccination. So what are our options for vaccination? And I'll go over the schedule and dosing of this vaccine because it's changing constantly. So currently there are 3 vaccines available for HPV. And as you can see here, it's the bivalent and quadrivalent, which were the original vaccines. And you can see that they were designed for certain types of HPV, where it says VLP, those are the different types of HPV. So 16 and 18 are high-risk HPV, 6 and 11, you see in the middle, are low-risk HPV. And the latest vaccine is the 9-valent, non-valent vaccine from Gardasil, where it covers 9 different subtypes of HPV, including both the high-risk and the low-risk subtypes. So most people these days are getting the Gardasil vaccine. And when do we give it? The guidelines have evolved over the last 10 years quite a bit. It used to be that this was only indicated for prepubescent females, age 11 to 12, but now they have widely increased the vaccine indications. So currently, routine vaccination should occur at age 11 to 12 years in both boys and girls. And if you're not vaccinated by then, catch-up vaccination should occur up to age 26, if not previously vaccinated. And then there's also a group of patients, 27 to 45-year-olds, where with their doctor, they can make a decision about whether the vaccine is right for them or not. The reality is that once you become sexually active, you're probably already exposed to HPV. So the value, the public health significance of vaccination after age 26 is quite diminished. And therefore, the vaccine is recommended really for everybody, just about everybody up to age 26. But as you get into older age groups, the value, public health-wise, of vaccinating is diminishing because most people have already been exposed to HPV. There is some debate about number of vaccines required. There's some research showing that 1 shot is enough. But the recommendation remains, under routine circumstances, 2 doses are sufficient and they're separated by 6 to 12 months. There are, in the catch-up vaccination group, and certainly in the older vaccination group, they recommend 3 doses as well as in high-risk patients. But most of the time, if it's done under routine circumstances, age 11 to 12 for both boys and girls, and 2 doses of the vaccine. So what about safety? And this is a big topic, and I think it comes up quite often with parents and with adults regarding the vaccine safety profile. And of course, COVID and what we learned about vaccination and vaccination hesitancy as a result of COVID probably plays into this as well. But the reality is the most common adverse features of the vaccine are mild. There are really no serious adverse events reported, or if there were, they're not clustered or patterned around the vaccine, hard to point to the vaccine as the cause. And the findings are very similar to Tdap and other vaccines that we already receive. And at this point, millions upon millions of people have received HPV vaccination since 2006. So how well are we doing? As I mentioned, the promise of primary prevention is through vaccination for this disease. And you can see here that there's a significant distribution in terms of the rate of vaccination across the US, ranging from 20% all the way up to 70% or 80% nearly in the Northeast part of the United States among 13 and 17-year-olds. When you look at folks who are 18 to 26, you see similar patterns, but you see, of course, lower rates in that higher in the older patient population. The question is, does it work? And what's the evidence that this works? And there is multiple papers from around the world where healthcare systems have been able to implement mandatory or highly recommended vaccination. One of them is in Australia, where 80% of school-aged girls were fully vaccinated. And they saw a significant decline in the precursors of cervical cancer, so high-grade cervical lesions, a reduction in genital warts by 93%, in both males and females. And this was by simply vaccinating 80% of all the girls in Australia. So this is evidence across a population that this is a cancer-preventing vaccine. It prevents other HPV-related diseases, but primarily it will result in a significant decline in morbidity and mortality for people who would otherwise be at risk for HPV-associated cancers. So what about in the US? As I mentioned, the rates have been increasing as awareness has increased, primarily among women. But there is a significant decrease when it comes to different racial and ethnic groups in the US. And you can see here, for example, non-Hispanic white compared to African-American and Hispanic. There are significant differences with respect to rates of vaccination. And this is something that requires an increase in awareness among all the communities in the US to really have the benefit of vaccination longer term. We recently wrote a paper that was published in the journal JAMA Oncology, where we looked at vaccination rates among people going from active duty military into the VA system. And we looked at patients who were 18 to 26 and then up to age 45. And we found that veterans are about half the rate of vaccination compared to non-veteran populations. And we see that there are regions of the country that have a very high number of young veterans and a very, very low rate of vaccination. And we can demonstrate to the VA system, to the federal system, that this will, in real terms, decrease the quality of life, shorten the lives of a significant number of veterans that could be prevented. And so, we spend millions upon millions of dollars now in the VA system for preventable cancers. And this is a really important example of that. So we hope that this study will kind of draw attention to the fact that we need some more guidance potentially in vaccination for our military community as they go from active duty military into the VA population. So let's talk a little bit about oncologic outcomes with oropharynx cancer. As I mentioned, the outcomes have been significantly better. So the good news here is that we have a cancer that's increasing in numbers, but the outcomes, their chance of cure, quote unquote, of these cancers is much improved compared to HPV negative cancer. And this is one of the most important papers showing that from the New England Journal of Medicine in the early 2000s, showing that the survival for these patients with oropharynx cancer was 80, almost sometimes 90% or more at 5 years, compared to 40 to 50% in HPV negative head and neck cancers. We also found, as I mentioned before, that there is this intermediate risk group. So patients who are HPV positive, but also heavy smokers, they don't do as poorly as smokers alone, but not nearly as well as HPV positive non-smokers. So this is a really interesting group, and we've investigated biologically why they have an intermediate risk. And we think it's actually related to the immune response being more robust in non-smokers compared to smokers. But this is a group that in the VA population, for example, is a very, very prevalent group of patients who both smoke and have HPV-driven cancer. So it's important, as we see patients who are smokers or non-smokers, we consider HPV in both populations because it has really important relevance with respect to prognosis and even treatment. So the treatment of this disease has changed over time as well. Oropharynx cancer, traditionally, at least since the 1990s, has been a disease treated non-surgically. And the reason is because the operations to remove portions of the tonsil or the throat are really, really morbid. To do an open operation sometimes involves removal of part of the jawbone. It can be crippling for our patients when it comes to swallowing and speech. So there was a big transition in the 90s towards doing non-surgical therapy, which was effective or as effective as big open surgeries for this disease. However, in the last 15 years or so, there's been a reemergence of surgery for oropharynx cancer as a result of transoral robotic surgery. And we have evidence now that the robotic surgery, when done in an oncologic way, can have a significant impact on the side effects of treatment by reducing the necessary doses of radiation. And part of that has fed into this idea that this disease, being biologically distinct from HPV negative cancer, doesn't deserve the same high intensity treatment as HPV negative cancer. So there's been lots of work done to show that we can treat patients with lower radiation doses or doing a minimally invasive surgery and then lower radiation doses and achieve the same outcome. So there are multiple studies across the country now, active and others that have reported, like this one that I was a part of when I was at UNC, showing that patients who have lower dose of radiation still have great outcomes, but their quality of life is better. They have less dry mouth than they would if they received the traditional high doses of radiation. But, you know, and surgery has been a part of that for some of these. You don't necessarily need to do robotic surgery to de-intensify, but the robot has emerged as a new tool. It's been an important tool for the management of HPV oropharynx cancer. Very different institutions have different approaches to using the robot. We tend to be a heavy robot practice when the tumor is amenable to it. There are sometimes cases of HPV-driven cancers that are not good candidates for surgery, and we therefore will give radiation and chemotherapy alone. But the robot has really changed the landscape of treatment. And this is an older version of the robot that's being used by Vinci here. And here's a little bit of the way the setup looks like in the operating room. You're in a console and you're managing these arms in the mouth, and they're able to follow the moves that you do with really great precision. So the robot is indicated for smaller tumors. We oftentimes will do the resection with the robot, and then we'll do a conventional neck dissection to remove lymph nodes out. And as I mentioned, a big part of treatment de-intensification, or reducing the overall dose and intensity of treatment, has come as a result of these minimally invasive surgical approaches. Dr. Ferris, who's the director of our cancer center here at Hillman Cancer Center, led the largest and really one of the most important foundational trials for the role of robotic surgery in head and neck cancer. And importantly, they found that when they introduced a robot and therefore were able to lower the dose of radiation, they had really excellent outcomes and less morbidity or less side effects of treatment by introducing the robot surgery earlier on. So we're very proud of this study as a big part of UPMC and the University of Pittsburgh. And it's also led to new studies. So our current clinical trial builds upon this and introduces novel approaches. And it's been interesting to watch how de-intensification has become more and more common in the clinical trial setting. I should note that not every patient deserves treatment de-intensification. And one of the challenges that we will face as we start lowering doses and doing minimally invasive things to try to make our quality of life for our patients better is a risk that some patients don't deserve it and they need more intense therapy because their cancers are biologically distinct or more aggressive than we might think. And what we really have to figure out as we really make this part of our treatment paradigm is when to de-intensify, when not to de-intensify, in order to provide the best outcomes for all of our patients. So in summary, HPV oropharynx cancer has dramatically altered the landscape of the epidemiology of head and neck cancer, the demographics of the patients that we see, as well as the outcomes in head and neck cancer. It really is the most important change that we've seen over the last several decades with respect to head and neck cancer. Robotic surgery offers the opportunity for treatment de-escalation, hopefully improving quality of life for patients compared to standard approaches. We have to de-intensify. We have an opportunity to potentially de-intensify therapy, but we have to find a way to do it safely. And the final note that's not on here is that vaccination is the key to primary prevention of this cancer. And the more we do it now, the less we will have of this disease 20, 30 years from now. So the efforts that we put into vaccinating our young people now will pay off for us in decades to come. And that's really a unique aspect of this disease that we should really all support. So thank you very much for your attention. It's really an honor to be able to talk, and I'm happy to answer any questions.
Dr. Zevallos, thank you so much. We are getting a lot of questions in. I made a mistake and forgot to tell people they could ask questions on the Q&A. I have a couple for you while we're waiting. So what I found so interesting on the international map is that the prevalence of HPV is the absolute opposite of the prevalence of HIV. When you're looking at like Africa, Europe, North America. I find that very interesting. Has that ever been looked at?
I think, what's certainly been looked at is folks with HIV who get HPV positive cancer, because HIV is an immunosuppressive disease, of course, and we think that in some cases it makes the HPV or oropharynx cancer more aggressive, or the risk of getting cancer higher. Why the geography of the map works out that way is hard to really understand. They're both sexually transmitted diseases, and I think that's what your point is, Heather, that they're both transmitted the same way. I don't have a good explanation or understanding as to why the distribution is so disparate, though.
Correct. Just was interesting looking at that.
Right. I think part of it too is that some of that may reflect the preventative mechanisms and the treatments that we have for HIV now, right? Where more modern, more developed countries have access to more preventative services or insight and knowledge into HIV, and therefore that's led to a decline. Whereas the same level of knowledge and insight on HPV or oropharynx cancer and the link between HPV and cancer may not be as defined.
Got it. Thank you. And then my other question, in looking at the map with veterans, the Veterans Administration is broken into clusters called VISNs.
Yes.
Are some of the VISNs more likely to work with younger veterans on vaccinations? I mean, is there an across the board way of doing things? Is it VISN by VISN, or is it just a total fluke?
Well, that's a great question, and I think part of the we're submitting a big grant to the HPV to the VA to look at HPV vaccination in that population, and one of our goals is to talk to VISN leadership and find a VISN who wants to help us pilot this work, right? Because currently there's not there, as far as I know, there are no strong recommendations, or definitely not anything compulsory for vaccination, HPV vaccination, either in the active duty military community or in the VA community. So I think to answer your question, the answer is no, there's not VISN specific projects, but there can be. And part of what we hope to do is convince at least maybe our VISN or other VISNs in the country to help us pilot some of this preventative work.
That's great. Thank you. Okay, we've got a couple questions. Got some really good ones. So first one, how commonly available is this type of robotic surgery at other hospitals around the country?
Great question. So the answer is it's becoming increasingly common across the country. There are the big questions to ask is that there's a lot of institutional patterns about how commonly we use it, and therefore experience levels can be very, very different across the country. So the fact that a robot exists somewhere doesn't mean that there's a competent robotic surgeon to use it for head and neck cancer, and that's a reality. The other important thing is that it's not just about the robot. The robot is part of a surgery that fits within multidisciplinary care. So for example, you can receive a great robotic operation that you then say, we're going to now reduce the dose of radiation to spare the side effects. But if the radiation therapist doesn't believe that, then you're going to get not only surgery, but you're going to get full dose radiation. So it's important that when you consider the use of the robot, it's considered within the context of a multidisciplinary team. It's not a surgery in a vacuum. So I think how common is the robot is becoming more common across big health systems. How common is the surgery within the context of this multidisciplinary team? That concept is less common. We certainly have it because we have a tradition of this work, but I'll tell you, it's not something you see everywhere.
Well, and on that note, does UPMC still have a survivorship clinic?
We have a survivorship clinic. That's great. And I think that's a big part of not just for HPV-driven cancers, but for all of our cancers in helping to understand better the side effects of radiation, how to overcome them. The key with our treatments is at the time of treatment, hopefully sparing those side effects by doing more minimally invasive techniques or lowering the dose of radiation. That can happen in many cases, but in many cases it can't. And I think the role of survivorship, or the role of speech and language pathology and all of the other services that we provide, are essential for all of our head and neck cancer patients.
And it's a wonderful clinic, one copay, get to see everybody there.
Right.
Are there any specific symptoms that would alert someone that they may have head and neck cancer?
Great question. So I think that it's the typical symptoms that one would look for are ulcers in the mouth or throat that fail to heal, for example, that you maybe treat with antibiotics, or you think it may be a cold sore, but they just fail to heal. And if they last for longer than 3 weeks or 4 weeks, then that's something to alert your doctor about. Sometimes bleeding from the ulcers can cause it. That's for mouth cancers. For the voice box, it's things like hoarseness or difficulty swallowing, unexplained weight loss are things to look for. And then in the neck, most of our patients with head and neck cancer will present with a lymph node in the neck, so a bump in the neck that fails to go down after antibiotics. So the typical story we hear is, I went to the doctor, they tried 2 rounds of antibiotics, but this thing persisted, and they finally made it to see me, right? And sometimes we find a cancer. As I mentioned, the risk with HPV positive cancer is the symptoms are much more vague. There's really no symptoms, oftentimes very little symptoms in the mouth and throat. The symptoms are presenting with a lymph node in the neck. So I think the things to be vigilant for are new non-healing lesions in the mouth and throat, unexplained weight loss or hoarseness or difficulty swallowing, and then a bump in the neck that fails to go down with time or with antibiotics.
Thank you. Is family history a leading factor in head and neck cancer?
Not directly. It's a great question. There are some genetic predisposition that we see for some kinds of head and neck cancer, but far and away, there's not a known genetic or hereditary link for the vast majority of the cancers that we see, including HPV cancers. Yeah, there is a very small minority of hereditary cancers associated with head and neck cancers that are associated with hereditary conditions, but I would say the vast majority, the answer is no.
Do most PCPs know how important HPV vaccination is? That's a great question.
I think it's a great question. I think most PCPs, understand the link between HPV and cervical cancer in women. That's a very clear understanding that's been around for a long time. What many PCPs and sometimes even ENTs don't know is this important link between head and neck cancer and HPV. And therefore, that means that maybe pushing or discussing the HPV vaccine with men is less common than with women, right? And frankly, these can be uncomfortable discussions, right? Because it's a sexually transmitted virus. So I think that gets in the way of this sometimes. But to answer your question, they've done surveys, and I think there's still a lot of work for us to do, not just with PCPs among adults, but with pediatricians as well, and even with otolaryngologists about the importance of vaccination. And really overcoming this as a sexual promiscuity vaccine, which I think early on, I hope that's changing, although it's hard to know, that it was linked really as a vaccine of promiscuity, when clearly it's a vaccine of cancer prevention. And the way we talk about it should change, right? It's really a cancer preventing vaccine and not anything to do with sexually transmitted infections.
Correct. So let me read this question to you.
Sure.
Please give us more details on why and how Pap smears are used to diagnose these various head and neck cancers, especially how they are used differently in men and women. And I'm thinking this question is about the difference in detection between men and women. Yes, it's a good question.
It's a good question. So Pap smears are not used in head and neck cancer. They are used in detection of precancerous lesions of the cervix in women. And the way they work is it's a brushing of the cervix that yields cells, and then a pathologist or a cytologist looks at the cells and looks at the features of the cells and tells you this is at risk of cancer. And then that then allows the surgeon to do a procedure or to hopefully get rid of the risk of cancer. Now, it's a great question because people have thought, well, if we can use a pap smear for cervical cancer, why can't we use it for the head, for the throat? Why can't we take a brush the tonsils, brush the base of tongue, and detect cancer before it develops? The reason why you can't is because, as I mentioned earlier, these cancers arise deep in the crypts of the tonsil. They don't arise on the surface. So a brushing will miss those cells that you need to find the cancers, because it's so far inside the tonsil and not on the surface.
Not on the
You could
surface.
miss it, yeah. So people have looked at saliva, and I've done some work on this where can you measure saliva, HPV in saliva? The answer is you can, but as I mentioned, if you tested everybody for HPV saliva, you're going to scare a whole bunch of people who will never, ever, ever get cancer because HPV infection is so common. And that's really the problem with screening for head and neck cancer, is we don't have a good screening mechanism for this disease because it's much more challenging than using a pap smear in cervical cancer.
And one more question. Does HPV cause uterine cancer?
No, it's a different, uterine cancer is very different. HPV, as far as I know, is primarily a disease of the cervix. So it causes cervical cancer, anal cancer, penile cancer, and head and neck cancer are the primary ones that it causes.
Gotcha. Thank you. And then one question about the vaccine. So has the HPV vaccine gotten as much bad press from the anti-vax community as other vaccines?
Yes, I think it has. And it's hard to quantify the bad press, but certainly I think in different parts of the country in particular, it's gotten very bad press. And I do think that the COVID vaccine hesitancy has probably added to it in some ways. But I think it's on all of us to really talk about this with our kids or our grandkids, so that as the next generation of folks get older and become eligible for vaccination, we should really be pushing it on everybody. And that will have long-term effects, societal effects on HPV cancer 20, 30 years from now. All the folks who are getting infected today, who are in their teens and 20s, they'll be our patients in 20 years. If we start today, we won't see a drop in this cancer for 20, 30 years. So we have to start sometime, right? And really get the word out there.
Oh, we got two more questions. This is great. If a female got HPV high risk and cleared it, even though she had been vaccinated, is she at higher risk for HPV oral cancer in her 50s and 60s? It's a very interesting question. Yeah,
it's hard to know it precisely because it's not. What I can tell you we do know is that if you clear it, if you go from detectable to undetectable, in saliva, your risk of getting cancer is much lower.
Okay.
And that's really as far as we know, right? If you're vaccinated, I think your risk is also lower because what the vaccine does, it triggers your body to create an immune response towards the virus. So even if it's present, it's going to be attacked more readily. And it's a great question, but the cancer does certainly occur in females. We see female patients, but it's predominantly a disease of males.
Okay.
Yeah.
Would people with suppressed immune systems be more susceptible to developing head and neck cancer if they have HPV?
The answer we think is yes. And it's hard to, I tried to do a study on this exact question years and years ago using big data and trying to find, looking at folks who have autoimmune diseases, taking biologic therapies or patients with HIV. We know that the risk is higher in HIV, certainly, especially if it's uncontrolled HIV. I can tell you anecdotally that the youngest patient I ever treated for this cancer was in their early 30s, actually, who got an HPV positive oropharynx cancer. And that patient had juvenile onset rheumatoid arthritis and had been taking biologic therapy, antibody therapies since they were young kids, right? And the only thing I can tell you, and this is anecdotal, this is one patient, but we do see it in this population. It seems, at least I think, potentially accelerate the latency period, right? Whereas it takes 30 years to get cancer in a immunocompetent person, it may be shorter time in an immunosuppressed patient. But again, there's not hard data on that.
Mhm.
I can tell you that if a patient came to me and said, I want to do treatment de-intensification, but I'm immunosuppressed, the answer is no way.
Right.
We can't, we know enough, I think, to say, let's not de-intensify therapy if you have this underlying immune condition, because I think we're setting them up to fail.
Thank you. So as we have just a few minutes, I would like you to talk a little bit about the head and neck cancer leadership that we have across multiple entities here at UPMC, including Otolaryngology
Right.
and Hillman and all these great things.
Yeah, so this is, thank you, Heather. This is a remarkable place to do clinical care for head and neck cancer as well as research. And the reason is because this is not a very, very common cancer to begin with. But as it turns out, myself as the chair of otolaryngology, the chair of radiation oncology, and the director of our cancer center, all three of us are head and neck cancer specialists at Pittsburgh. And that's unheard of. There's nowhere else in the country where that's the situation. And I think it speaks to, number one, our legacy as leaders in head and neck cancer care, not just surgery, but the whole picture of head and neck cancer care. It also speaks to our strength as researchers. You know, we have, we're one of 3 institutions in the whole country with a National Cancer Institute grant called a SPORE grant that supports head and neck cancer research at Pittsburgh. And it also speaks to the innovation that we're doing on a daily basis. So I think it's a very important and place to receive and to treat head and neck cancer, as well as to do research. Our clinical trial portfolio is among the largest in the country for head and neck cancer because so much of our resources are focused on this one disease. So really is a pleasure to work here and to be able to treat patients here.
Well, we're happy that you're here. So thank you. We did get one last question, and then that'll wrap it up for today. OPSCC in younger patients may be related to Fanconi anemia or other DNA repair defects?
So as far as we know, Fanconi's it is primarily related to oral cavity cancer. So OCSCC, I guess. Yeah, oropharynx cancer, as far as I know, it may not be, it's not related to Fanconi's. The Fanconi's patients that we see tend to be younger patients who are non-smokers, have no other risk factors, and present with oral cavity cancer. So what's interesting about that question is that, you know, when you distinguish the mouth, the oral cavity from the oropharynx, we're talking about millimeters of difference. But as I mentioned earlier in the talk, the tissues, the composition of the cells in the tongue and in the oropharynx are very different. One is lymphoid tissue, one is not. And we think that the cancers that we typically see with Fanconi's are more of the non-HPV, non-lymphoid tissue cancers. Even though they occur in close proximity, they're not linked to oropharynx cancer.
Okay. Well, Dr. Zevallos, thank you so much. It's been a great first year having you here.
Thank you very much.
Doing many more of these webinars with you and in the years to come, and seeing your leadership on head and neck cancer. So to all of our attendees, thank you so much for joining us today, and we will see you in a few weeks. Take care.